All right. Okay, so disclaimer. Also, student, have not seen the exam. I do not know what is on the exam and what you're going to be tested on. So don't ask me, is this on the exam? I don't know, for one. For two, like, is it in the course pack? Yes or no. Is it in dissector? Yes or no. All right, was it presented in lecture? Yes or no. Okay, so take that for what it's worth. All right, so the goals for this one structure, we're applying our knowledge to clinical presentations. I don't know why there's recordings on these slides, but familiarize yourself with how anatomy will show up on your future exams. So this is including your MBMEs and your STEP exams, which you'll see in the future. Integrate content from multiple course pack chapters into a single clinical vignette, which oftentimes you don't get to do until the exam, so this gives you an opportunity to do that. And expect a lot of call and response. This is a review lecture. Y'all are at the point where you are getting ready for the exam, so make sure that I'm going to ask a bunch of questions, ask for responses. The more engagement you get, the more you'll get out of this. And if anyone bullies you for getting something wrong, I'll bully them, so don't worry. All right, so first case. So we have a 68-year-old male presenting to the emergency department with severe abdominal pain radiating to his back. He reports feeling dizzy, weak. On exam, he has a pulsatile abdominal mass and hypotension. CT of the abdomen reveals an abdominal aortic aneurysm located just inferior to the renal arteries with evidence of impending rupture. So the aneurysm is significantly disrupting blood flow to all distal branches of the abdominal aorta. Okay, so in this clinical case, you're looking at a AAA, and then the questions here that we're going to be looking at is, what are the branches of the abdominal aorta? How is that going to be impacted with blood flow that's distal to the renal arteries? What kind of, if there's disruption to that blood flow, what would you see going forward? So the first thing we're looking at, what are the branches of the abdominal aorta? Oh, and also these slides, you'll see, because y'all haven't got a chance to see a bunch of clinical cases, every slide will show this is the information that tells you the key points that you need to pick up on. So part of learning how to do clinical vignette style questions is picking up on what is extraneous information and what information is important in order for you to make the diagnosis. So in this case, it gives us a CT and tells us there's a AAA, and now we just have to answer questions based off of that. So starting off, branches of the abdominal aorta. So where do it says we're distal to the renal arteries. Around what lumbar level do the renal arteries come off? L1. Okay, so what is the anterior branch of the abdominal aorta that comes off at that same level? Superior mesenteric artery, so SMA, coming off at L1. What is the lower inferior branch that comes off right underneath it? IMA, inferior mesenteric artery, and what lumbar level does that come off at? L3. Okay, so we're looking distal to the renal arteries, so that's where the aneurysm is. If it's saying blood is disrupted distal, then everything more proximal to the heart is going to be okay. Distal is going to be interfered with. So in this case, let's go ahead and look here at the branches of the abdominal aorta. So this pulls in, it's listed anterior, lateral, and posterior. This is the way that's listed in your embryo chapter as well. So there's different components that you need to know. But the anterior branches are the celiac trunk, SMA, and IMA. These are supplying your GI system. All right, when you're looking at the lateral branches, you have your inferior phrenic, which is the first branch that comes off laterally. What is a branch of the inferior phrenic? Superior suprarenal. So superior suprarenal, we'll differentiate it later from inferior suprarenal and middle suprarenal. But superior suprarenal coming off the inferior phrenic. You have the middle suprarenal, which comes directly off of the abdominal aorta. So you'll see it directly coming off the abdominal aorta going into the suprarenal gland. Right? And then you have the renal, which we said was at L1. And then gonadal, where does that come off at lumbar level? L2. Okay. And then your posterior branch, you have lumbar branches that go with the different segments. Okay. So a couple cadaveric images to keep track of. We'll come back to this. But what vessel is this that comes down kind of to the lower right quadrant? SMA. Because SMA is going to come down. And what is that vessel that is going right over top of? Left renal. So we'll talk about this later, but it's really important that the SMA crosses over top of the left renal vein, and that can cause nutcracker syndrome. Okay, and we'll talk about that presentation in a moment. And then so what is this branch? So this SMA, superior, what's the branch that comes inferior and goes to the left lower quadrant? IMA. And when does the IMA switch from inferior mesenteric artery to superior rectal? After it crosses over top of the common iliac. Right, so after that division. All right, so this question was asking specifically about what region of bowel is going to become necrotic if you have an abdominal aneurysm distal to the renal arteries. So we're below the region of L1. Okay, so what branch goes to the bowels after L1 as you're going distally? That'll be your inferior mesenteric artery. So what region of bowel does your inferior mesenteric artery supply? Descending colon, superior rectum. So this is where we're talking about embryonically, foregut, midgut, hindgut. Hindgut. So the region of the hindgut is going to be disrupted if you're damaging the blood supply to the IMA. Okay. So in general, breaking it down in regions, foregut is going to supply your GI system up to what point? Yeah, so it supplies the first part of the duodenum, so it gets the superior part, doesn't quite get the descending. There's a little bit of collateral flow, but then we're going to say the descending part all the way to where is the midgut? Splenic flex. So you're looking at the anterior or the proximal 2/3 of your transverse colon, distal 2/3, and all the way down to your rectum is going to be your hindgut. Okay. So in this case, we're saying wrong way. IMA is disrupted, so you're losing blood supply to this region. Okay. So that's kind of the clinical case that we're looking at there. All right, so for our second case, we have a 22-year-old female presenting to the emergency department with a 2-week history of intermittent abdominal pain, nausea, vomiting, weight loss. Okay, so it's been going on for 2 weeks. So it's not acute, it's progressive. She describes the pain as worsening after meals and located in the upper abdomen. All right, on exam, she appears thin with a notable loss of subcuticular fat. Her vital signs are normal, but she exhibits signs of mild dehydration. Makes sense that she's been vomiting for 2 weeks. Okay. A CT scan of the abdomen reveals compression of the third part of the duodenum by an overlying vessel, situated between the abdominal aorta and the vessel in question. So what vessel is likely causing the problem here if it's going over top of the horizontal component of the duodenum, so that's the third division, compressing against the aorta? SMA. So this is the superior mesenteric artery. So for us, we talk a lot about, and because one of your clinical correlations, the SMA compressing the left renal vein. Okay, because if it compresses the left renal vein, that's called nutcracker, and we'll talk about that in a moment. But in this case, it's not compressing the renal vein, it's compressing the duodenum. So it's going to present almost like a small bowel obstruction. Okay, so in this case, if it's the third part of the duodenum, are you going to expect that the vomit is going to be bilious or non-bilious? Bilious. Anything past what part of the duodenum is going to result in bilious vomiting? Anything past the descending part, because what drains into the descending part of the duodenum? Common bile duct. What joins the common bile duct right before it enters coming from another gland? Pancreatic duct. Okay, so the pancreatic duct joining the common bile duct. And then what's the space that it's coming into? Ampulla vater. Okay, and then going into the descending duodenum. All right, so, and then we talk about the other clinical correlation is going to be nutcrackers. So again, important things we're looking at here, vomiting. It's been, the 2 weeks is important as well. It's not acute. Worsening after meals, and its compression by the duodenum. So here, the big thing for the SMA pathway, the SMA is going to come off of the abdominal aorta, and it's going to cross over top of 3 structures. All right, so we've already talked about 2 of them. The left renal vein coming across from the inferior vena cava. It's going to cross over top of the horizontal component of the duodenum. And what's that other component? The uncinate process of the pancreas. Okay, so it's coming across all of those. So you can see that here coming across. So there's the uncinate process, duodenum, and you don't see the left renal vein in this image. Okay, so now we're talking about the superior mesenteric artery. So we talked about the inferior mesenteric, now superior mesenteric, associated with midgut, hindgut, foregut, midgut, associated with midgut. So it's going everything from the descending duodenum all the way to the proximal 2/3 of the transverse colon. Okay, so big thing here, you have the jejunal branches, which has few arcades, long vasa recta. Okay. The ilioarcades, as you go further down, you have more arcades with the vasa recta getting shorter. But remember, if you're in lab doing this, unless you can see both sides, you can't compare cadaver to a cadaver over there. Okay, you can't just say this looks long, all right, this looks short. You can only make that comparison on the same cadaver. So jejunum is going to be coming directly from the duodenum. So duodenum going to jejunum, and then it will transition to ileum, which will go into the large intestine. What is that juncture called, where it goes from the ileum to the large intestine? Ileocecal junction. Okay, so you're looking at, is it proximal to the cecum or is it proximal to the duodenum? What is a structure that you can use in lab to identify the transition point between the duodenum and the jejunum? It might hold up the duodenum. Maybe suspend it up in air. All right, so this is going to be suspensory ligament of the duodenum. Okay, so this is really that transition point. This is something that's used primarily in the OR, so because that is a structure that you can find that transition point. Because it's also going to be the transition between things being retroperitoneal and coming back into intraperitoneal. All right. One thing that's not shown in this image is the inferior pancreaticoduodenal vessel. So you do need to know that's coming off of the superior mesenteric artery. It's coming out. You have an inferior one off of the SMA, and you have a superior one coming off of the celiac trunk. Okay, but specifically the gastroduodenal coming down. Correct. All right. All right, so SMA syndrome. So again, y'all talk about nutcrackers. This is SMA syndrome. This is actually the one I got on step 1. So SMA syndrome is talking about the duodenum coming down, and the SMA is compressing it. So it presents as a small bowel obstruction. You kind of saw that nausea, vomiting, and it's going to be bilious vomiting because it's distal to the descending duodenum. All right. Okay. And then nutcracker syndrome. Y'all have probably talked a lot about this one. It's the left renal vein, because the left renal vein is coming from the inferior vena cava. So remember, the inferior vena cava isn't symmetric on either side. Right, on the left side, you come across as a left renal vein, and then it's going to give off its branches. So what are the 3 branches of the left renal vein? So you have the continued renal. What's the one that's up above? Suprarenal. What's the one below? Gonadal. Okay, so I compress the left renal vein. All right, that means that blood is going to back up in all of those regions. Okay, so if it backs up in the gonadal vein, say I'm a male, backs up in the gonadal vein, and that vein becomes tortuous, dilated, what is that called? So that if it's the vein that's dilated, it'll be a varicose. Right, if there's fluid in the pouch, that'll be a hydrocele. Okay, if it's a back up into the kidney gets damaged, I start to have blood getting into the glomeruli. That's going to present as blood in your urine. Right, so that's different things that you can see. And so if you see males with hydroceles, varicoceles, and it's on the left side, then you might be thinking, oh, let me make sure that there's nothing compressing the left renal vein. Okay, a lot of times that will happen in different kind of cancers that are in the abdomen. All right, any questions there? Okay. All right, so next case, we have a 55-year-old male, long-standing history of alcohol-related cirrhosis, presents to the emergency department with increased abdominal distension, lower extremity edema, and episodes of hematemesis. So using all the words that you'll see in the future about hematemesis, vomiting up blood, on exam, he has jaundiced skin, so his skin is yellow, a distended abdomen with a fluid wave. That tells me that he has fluid in his belly, and prominent veins visible around his umbilicus. Laboratory tests show elevated liver enzymes, low albumin levels. Imaging confirms the presence of ascites, again, fluid in the belly, and reveals splenomegaly. Right, further exams suggest portal hypertension with associated varices. Okay, so this whole case is talking about portal hypertension. In this case, it's alcohol-induced due to cirrhosis of his liver. So what are the vessels that drain into the portal system? So give me so I heard splenic. What's superior mesenteric, and there's one more. Inferior mesenteric. Okay, so inferior mesenteric vein oftentimes drains into which of those? Splenic, and they come together to form the portal vein. Okay, portal vein is anterior or posterior to the inferior vena cava when it's going into the liver. Anterior. Why is it anterior? Because the inferior vena cava runs along the back, it's retroperitoneal along its course. The portal vein, what is the goal of the portal vein? It is draining what structures? Your bowel, your gut. Does your gut sit in front of your aorta or behind your aorta? It sits in front of your aorta. So the portal vein, which is draining the gut, also needs to sit in front. Okay, so the portal vein is going to drain along with the portal triad. Is it going to sit in front or behind the cystic duct and those structures? Now it's going to be posterior. So be careful that what is the reference that you're using. Okay, so in the portal triad, it's going to be the most posterior structure, but when we're talking about draining into the liver, it is anterior to the inferior vena cava. Okay. Okay, so we talked about the veins that drain into the portal system. Key sites of portal systemic anastomoses, we'll look at these, and why we have dilation. It says here that there's dilation around the belly. You have prominent veins. What is that called? Caput medusae, and we'll talk about why that is. Okay, so we don't need to know not just that, oh, this is what this is, I can identify it, but what is the cause? In this case, it's portal hypertension, but we need to know what are the two, the portal caval anastomoses that are causing this. Okay, and then we'll talk about how ascites is causing this as well. All right, so your portal system, again, draining the GI tract. So remember that the GI tract is supplied, the arteries that supply it are your celiac, SMA, IMA. You don't have an equivalent to that to your inferior vena cava. Okay, why is that important? Well, let's say Ryan isn't paying much attention. He goes and eats a berry. He eats the berry. Okay, it's got some poison in it. I don't want that to go directly into my systemic circulation. Okay, so I need to detoxify that. Okay, or maybe I'm just out Saturday night after a football game. Either way, I need to detoxify, so I'm going to let it go to my liver first. Okay, before it gets into systemic circulation. So all of these structures are draining to the liver to detoxify the blood, does some other stuff as well, and then it's going to go into the inferior vena cava to get into systemic circulation. So the comparison is the anterior branches of your abdominal aorta are the equivalent of your portal system. Okay, but you don't have those equivalents on the inferior vena cava itself. All right, So big things here, we talked about the splenic vein coming across. The inferior mesenteric vein comes up. Oftentimes it'll drain into the splenic vein, join with the superior mesenteric vein, and that will form the portal vein. And that will go into the liver. Here we can see it a little bit larger. I'm actually going to skip this one because I want to show the portal cable anastomoses. So an important thing about the portal system, has valves, doesn't have valves. Doesn't have valves. Okay, that allows blood to back up. Okay, so this can cause dilation at the junction where you have the portal system and the vena cava system coming together, and that's going to cause varices. Okay, so there's three major regions that we need to be concerned about. The first one, probably the deadliest, is going to be where your left gastric, which is part of your portal or caval system. Portal system, okay. It's also color-coded for, I'm sorry for those that are colorblind, but portal is going to be in red, caval is going to be in purple. So left gastric is going to be portal. All right, the esophageal veins are from your vena cava, or like off of that system. So they have a junction or anastomosis where they come together. When there's backup, you get esophageal varices. Okay, esophageal varices are very dangerous because they're on our esophagus. Maybe I eat something like, and it has, I don't know, the chicken bone that used to got stuck in my piriform recess. It finally goes down. It's in my esophagus. It ruptures one of those varices, and then all of a sudden there's massive bleeding. Okay, so that's a medical emergency. The superior rectal connects with the middle and inferior rectal, so this is caval, this is portal. That can cause internal hemorrhoids because it's the superior rectal. Y'all will talk about this more in next exam, but there's a major difference between internal hemorrhoids and external hemorrhoids, so superior and inferior. And so the superior ones can often be caused by portal hypertension, amongst other things. We already talked about caput medusae, so that's the veins along the belly. Okay, so the portal component for this is the periumbilical veins, and then the caval system is the superficial abdominal veins. Okay, so when you're asked a question like this, you recognize someone has esophageal varices. Okay, what backup from which of these vessels is going to cause this presentation? It's backup from the portal vein into the left gastric, causing varices in the esophagus, causing the esophageal varices. Does that make sense? So making sure we can pair each one of these with a clinical presentation. What is the specific vein that's causing it? Okay. All right. Speaking of, yeah, sorry.
Will the backup always happen in the portal system?
So it's where the veins from the portal system is backing up because of hypertension in the liver causing backup of fluid, and there's anastomosis between the portal system and the caval system. So it's that anastomotic point that's backing up. Does that make sense? Okay. So one of the things I mentioned was the portal triad, what's anterior, what's posterior, what's left and right. So what's the anterior right component of the portal system? Artery, duct, or vein? Duct, because the gallbladder sits on the right. Okay, what is the anterior left component? Artery. And posterior? Vein. What do all of those structures run through? Hepatoduodenal ligament. Okay, so the hepatoduodenal ligament is part of your greater or lesser omentum? Lesser. Okay, lesser omentum has another ligament, hepatoduodenal and the hepatogastric. Okay, those are the two. But the hepatoduodenal, in my mind, is more important because this is the one that I'm going to look for to identify different spaces. So what is the space that's right behind the hepatoduodenal ligament, underneath the liver, before I get to the inferior vena cava and above the duodenum? So this circle here. Okay, mental foramen. So I kind of went through, those are the borders that you need to know for the mental foramen. But this is the foramen of Winslow. That's how you might also see it. But the hepatoduodenal ligament is allowing for the portal triad to pass through, and it's also allowing for transmission between the into the lesser sac, okay, which is posterior or deep in here after you go through the foramen of Winslow. Okay, questions there? Yeah.
What's the difference between the mental foramen and the porta hepatis?
So the portal hepatis is where the structures are passing into the liver. The mental foramen is space that allows transmission from the space in front of the greater omentum back into the lesser sac, which is behind the stomach and along the curves. And I think there might be an image up here at some point for that. But the omental foramen is a passageway. Okay. All right. Okay. Doing good on time. Okay, so a 63-year-old male, history of pelvic ulcer disease. Okay, presents to the emergency department with sudden, severe abdominal pain and signs of shock. So again, for any vignette, it's important to know, this is for the future when you're thinking about pathology. Is it acute, happening all of a sudden, or is it something that's progressive over time? Progressive over time, maybe it's cancer. If it's acute, maybe there's a rupture. We'll see what this is. In this case, history is important, pelvic ulcer disease. So there's erosion into the the bowel. So severe abdominal pain, signs of shock, hypotension, tachycardia, so his heart rate is high. The report said the pain began abruptly and is localized to his upper abdomen. On exam, his abdomen is tender with guarding. So guarding means that he's covering it, he doesn't want you to touch it. Okay, that's a sign of very severe abdominal inflammation. All right, laboratory results reveal a significant drop in hemoglobin. Hemoglobin is in your blood, right? So a drop in hemoglobin would indicate that there's bleeding, likely is the case. And an emergent endoscopy, so that's a tube down the throat, identifies a posterior wall ulcer in the descending part of the duodenum with active bleeding. So the ulcer has gone into the posterior wall of the duodenum. It's now touched an artery, causing that artery to rupture, and there's bleeding that's occurring. Okay, so behind the descending part of the duodenum. Imaging suggests that the ulcer has already through the wall, involving the artery directly posterior. So this question is basically saying, you have an ulcer, it's gone through the duodenum, posterior, descending, what vessel was it going to touch? Okay, so what vessel runs behind the duodenum? Gastroduodenal artery, which is coming off of what vessel? So it's the celiac trunk. The celiac trunk gives off the common hepatic, and then that's going to split into the proper hepatic going up, and then the gastroduodenal going down. So in this case, it's saying what vessel is running behind the descending part of the duodenum. Okay. All right. And then we're going to talk about the rest of the branches of the celiac trunk, and then what gut tube is celiac trunk associated with? What foregut, midgut, hindgut? Foregut. Okay. All right. So branches of the celiac trunk, as we come through, celiac trunk is coming off. What is this branch coming up around the lesser curvature on the left side? Left gastric. Okay, this is so there's three primary branches of the celiac trunk. Left gastric is one. It's everyone's favorite because it doesn't have any other branches that we need to know. Okay, at least for this. So then we have the one that's coming over here all the way to the spleen. What is that? Splenic. And our other main branch, we already talked about it, coming across to the liver. Common hepatic. Okay, so as the common hepatic comes across, it's going to give off a branch that goes inferiorly. It's going to be running behind the duodenum. That is our gastroduodenal artery. We'll see another image that'll show the different branches of the gastroduodenal artery. But the continuation of the gastroduodenal artery as it comes around and goes then on the inferior border of the stomach along the greater curvature is going to turn into what? Right gastroepipular or gastroomental. Okay, so that's coming in this way. We talked about that there was, so there's a branch off of the proper hepatic that comes along the lesser curvature from the right side. So here was from the left, here's from the right. This is the right gastric, okay? And then the proper hepatic is going to come up. It's going to bifurcate into a right and left hepatic artery. Off of the right hepatic artery, because on the right side where the gallbladder is, you're going to see the cystic artery going into the gallbladder supply with blood, okay? So then the splenic artery, the main vessels that you need to know that are up here are splenic arteries coming across. It's going to the spleen. There are short branches that come off the splenic artery to supply the superior pole of the greater curvature. These are the short gastric, okay? And then the continuation that comes down inferiorly along the greater curvature is the left gastromental or gastroepipulic, okay? So this is, y'all have seen this drawing before, but the idea here is that these are just listed, all the structures, but I want to show y'all this, the arteries that supply the duodenum, pancreas, spleen. This is, some of these you don't need to know, so we're just going to point out the ones that you do. So celiac trunk coming down. So if this is coming off, it's not the splenic, it's not the common hepatic, that must be the left gastric. Okay, you see the common hepatic coming across. This part of and this is the gastroduodenal coming down. So all of this is going to the liver or the gallbladder. This is the common gastroduodenal coming down. As the gastroduodenal comes down, it's not shown on this image, but what's the first branch that y'all need to know coming off? Supraduodenal. And then what's the one that goes down to supply the duodenum and the pancreas? Superior pancreaticoduodenal. Okay, so off of the celiac trunk, the gastroduodenal comes down. You have the superior pancreaticoduodenal. Where does your inferior pancreaticoduodenal come off of? SMA. So make sure you delineate those two. So you have a superior, that's an ventral branch of the celiac trunk, and then an inferior that's coming off the SMA. Okay. And then two branches that come off the splenic artery that supply the pancreas. The first branch that comes off is the dorsal pancreatic artery. Second branch to come off is the greater pancreatic artery. Okay, so I think alphabetical, D before G. Dorsal, then greater. Go from there. And then we talk about the other branches. Okay. Any questions there? Yeah.
So, wait, where is dorsal again? So it comes off, that's the first.
First branch, and greater is second. All right. Okay, so this question you will see in your sleep This is something that comes all the time. I don't think I've ever taken an exam without this presentation. So a 16-year-old male presents to the emergency department with 24 hours of abdominal pain. He describes the pain as initially vague, it's centered around my belly, mid-abdomen. It gets worse over the past several hours, and all of a sudden it's sharp, shifted to the right lower quadrant. He also reports nausea and a low-grade fever. On exam, there is tenderness at McBurney's point. McBurney's point's right over the right lower quadrant, and rebound tenderness. So rebound is where I push on the belly. Y'all probably done this in OSCEs. I let go, and they're like, ow, the pain's over here, even though you press on the other side. So it's when you let go, it's a sign of peritoneal inflammation. All right, patient's diagnosis associated with the inflammation infection of what structure? Appendix. Okay, so classical presentation of the appendix, or appendicitis, you're going to have non-localized mid-abdominal pain, like periumbilical, and it's going to shift to the right lower quadrant. So what is causing the vague, non-specific pain to the shift? So the non-specific pain is, what's going on there? So that's going to be this is going to be your visceral pain, right? It's non-specific. It's running with, what's the dermatome associated with the umbilicus? T10. So appendix referring to T10. So this is referred pain, right? Then as it begins to shift inferiorly into the right lower quadrant, okay, what is happening there? What's getting inflamed? The peritoneum. Because what part of your peritoneum is pain sensitive? Parietal peritoneum. So as the inflammation continues, as it gets more inflamed, as it begins to irritate the parietal peritoneum, it's going to localize to the right lower quadrant, which is where the appendix is. Appendix is coming off of what part of your bowel? Cecum. Okay, awesome. Okay, and then we're going to talk about the dermatomes associated with the heart, gallbladder, and kidney. So heart, what are we thinking? So we know, pain in my shoulder, it's radiating down. This is my scapula. So what are the dermatomes there? T1 to T5. Gallbladder, we're thinking T7 to T9, which often refers to where? Subxiphoid or epigastric pain. Okay. We said the appendix, we're thinking T10, which is periumbilical. And then my kidney in the back, oh man, I've got a stone that's radiating. I feel it down coming into my groin. What are we thinking? Thinking in the region of L1, which is going to end up suprapubic. Okay, so we'll see those. But referred pain, the idea here is that the referred pain is occurring when there's visceral pain that's presenting with as somatic symptoms. Okay, and this is because, remember, if you think about, for the abdomen specifically, all of these visceral pain fibers are going to be with the sympathetic distribution. All right, so you remember you have your sympathetic plexuses. They're coming down. You got your greater splanchnic, your lesser splanchnic, your least splanchnic. So greater splanchnic has spinal segments T5 through 9. Okay, your lesser 10 and 11, and least 12. Okay, so they just keep descending. All right, and then sympathetics, they can only arise from the spinal cord from where? What spinal segments? T1 through L2. So if I want to have more sympathetics and I go past the lesser splanchnic nerve, what are the next splanchnic nerves called? So in this case, there could be lumbar, and they're L1 and L2. And what's the difference between the upper lumbar and lower lumbar? Are the spinal segments the same? So the lower lumbar come out of the vertebral column at a different location, but it's still the same spinal segments, L1 and L2. Okay, so that's the kind of those are somewhat tricky, but those are sympathetics. All right, and the issue is that you're having pain going to the viscera, so the organs. So that pain is going back up through the spinal segments with the sympathetics that distribute to that organ, and then you're feeling that pain in the somatic distribution of that same dermatome. Okay, but then again, as the peritoneum becomes inflamed, that's where it's going to localize. So in this case, here's a dermatome map. You can see periumbilical T10. You've got T7, T9 kind of in the inferior, right below the xiphoid process, and then L1 coming down into the groin. So when you see people talk about kidney pains, it'll come shooting across. Yeah.
What's the difference between the subcostal nerve being T12 and the least sympathetic?
Yeah, so difference between sympathetic fiber coming off of the splanchnic nerves. So splanchnics for sympathetics, they run into the sympathetic chain, don't synapse there, continue out through the anterior component of the sympathetic chain, and then distribute to the plexuses that they're associated. The subcostal is just like any of the, like brachial plexus, lumbar plexus. It's not a sympathetic fiber, it's a somatic fiber that's coming through, because that's the subcostal. Okay. Now, that means it could have sympathetics in it, but the difference there with T12 is just the same spinal segment. Right? And y'all have seen multiple nerves that have the same spinal segments as well. Okay. All All right, and then migratory pain. So again, very common presentation. Periumbilical pain localizing to the right lower quadrant over time, usually with a fever, with some nausea, some vomiting, some abdominal inflammation. Questions there? Cool. All right. All right, so we have a 28-year-old male presenting to the emergency department after sustaining a gunshot wound to the inferior right back. During surgery, it's discovered that the bullet traveled through the abdominal cavity, passing just lateral to the right psoas major muscle. So it passes lateral to the psoas. The patient is stabilized and necessary repairs are made. During a follow-up visit, the patient reports decreased sensation to his right scrotum. Okay. He denies any other symptoms, including weakness or motor defects. So, shot in the back, goes to the right or lateral to the right psoas muscle, comes through, decreased sensation to the scrotum. What nerve passes across the posterior abdominal wall, lateral to the psoas, that can lead to loss of sensation to the scrotum? Ilioinguinal. Okay, ilioinguinal here. And why would I not jump to, oh, this is genitofemoral? Because I said there's no loss of muscle here. And I could have said, like, there's no loss of cremaster reflex. That could help us with that as well. But in this case, lateral to the psoas, damage, we're thinking ilioinguinal. Okay, sensation only. Spinal segment for ilioinguinal, L1. So as we go down the lateral abdominal wall, posterior abdominal wall, what are we thinking what's the other branch is L1? Iliohypogastric. All right, just superior to those, along the posterior aspect of the abdomen, you'll see something that's T12. What nerve is that? Subcostal. We talked about genitofemoral. Genitofemoral is what spinal segments? 1 and 2, L1 and 2. Okay, and then we'll see the other ones on the wall in just a second. All right, so gunshot wound through the back, just lateral to the psoas muscle. Goes through muscle. What muscle is it passing through posteriorly? Quadratus lumborum. So remember, in the posterior abdominal wall, there's going to be two big muscles that you're going to see. The psoas is going to be the one more medial, and then lateral to that is going to be the quadratus lumborum. All right. One thing that we need to know about the muscles in the abdomen, in the posterior abdominal wall, the diaphragm is separating the thoracic cavity and the abdominal cavity. At the bottom of the thorax, or the bottom of the diaphragm, you're going to have arcuate ligaments that are coming across. So you have a median, medial, and lateral. Okay, so it's important that we can see those ligaments and see what structures are passing through or making that arch. So the median is going to be formed by the crura of the diaphragm, what passes between the crura of the diaphragm from the thorax into the abdomen. That's going to be your abdominal aorta, right, coming through, so thoracic aorta going into abdominal aorta. So that's your aortic hiatus region. All right, and then lateral, we have a muscle. So median in the middle, medial, lateral. What's that going to cause? Psoas. And then I go even further lateral, we have the quadratus, okay, which is the one that this person got shot through. Okay, so we're going to look at those. So again, here's the information. Decreased sensation to the scrotum, lateral to the psoas, no loss of motor sensation. Help you identify what nerve is likely involved. And so a lot of this is past what y'all need to concern yourselves with, but this is the lumbar plexus. I don't know what happened to the bottom half. But the lumbar plexus will be in y'all's next course pack chapter. But again, you can see these in lab now. Okay, so you can see the nerves, know the nerves and their spinal segments. The big thing here is this is kind of what it's going to look like in lab. So you have the psoas major, which is medial, close to the vertebral column. Quadratus lumborum is lateral. Okay, as you come across, here's your subcostal nerve. So this is spinal segment T12. Then coming right underneath it, this can oftentimes present as a single nerve that bifurcates where you can see it, or two nerves that come across the posterior abdominal wall. But if there's a nerve on top, it's going to be your iliohypogastric. One below is going to be your ilioinguinal. So those are both spinal segments L1. All right. Then coming through the psoas down, it's going to bifurcate. One branch is going to go to your thigh. One branch is going to go to, and if it's in males, into the scrotum. What is this nerve? Genitofemoral. Spinal segments L1 and L2. Okay, over here coming, so this is behind the psoas coming across. This is the iliacus muscle, don't worry about it. It's coming across, and it's going to go down towards the thigh. Lateral thigh is going to be so this one's going to be your lateral cutaneous femoral nerve. Okay, lateral cutaneous femoral. Spinal segments L2 and L3. Okay, lateral cutaneous femoral. Okay, now, hard to see here. If I take the psoas muscle and I pull it laterally, so I can see in between, and remember you're going to have your vessels here, so it's really going to be between your aorta, celiacs, and psoas, and I look deep. There's a nerve that's very tight, under a lot of tension. What nerve is that? The one you see on top. Obturator, spinal segments, L2 through L4. If I go deep to that, so I push the obturator to the side and I look in deep, there's a trunk. What kind of trunk is that? Lumbosacral trunk. Okay, and that's going to be L4 and 5. What is this nerve? So it's psoas, comes through, it goes underneath. What's this ligament? So this is the inguinal ligament coming across. So this nerve that passes underneath the inguinal ligament into the thigh, that's going to be supplying all the muscles. Y'all learn them up here in the anterior thigh. That's going to be the femoral. Spinal segments, L2 through L4. So I like just starting from the top, work my way down. Subcostal, T12. Ilioinguinal, iliohypogastric, L1. So T12 to L1. Genitofemoral, L1 and L2. Lateral cutaneous femoral, L2 and L3. Femoral, L2 through 4. Obturator, L2 through 4. Just work my way down with the spinal segments. Okay. Any questions there? Yeah. See it on the next slide. Okay. So you're one step ahead of me, but great question. So we're going to see real quick the muscles. So just so you can see them kind of colored here, we're going to have the psoas. You have a psoas major, psoas minor, the quadratus lumborum located laterally. All right, here's how it's going to look on the cadaver. So here's your psoas minor, psoas major, quadratus lumborum. And then right here, this is where you're seeing the ligaments, the arcuate ligaments. So lateral here, over going across the quadratus, medial, AL, and then median. Yeah.
So I guess I was having trouble with the factory person. Not the embryological significance, but maybe how you were describing it with the posterior abdominal wall a few minutes ago.
Yeah, so just that when you're looking here, so this is all posterior abdominal wall. Yep, and I can look back and see where there's that transition point where the diaphragm is, where it's attaching. You have those ligaments that are forming. So it's really just because I can see it on the posterior abdominal wall. And then embryonically, remember we have different components that make up the diaphragm. Not going to do a whole bunch of embryo because I don't remember a bunch of it, but that's make sure that we know all of that. One thing I do remember about the diaphragm, won't forget it. What the diaphragm initially, the major component of the forming muscular part, starts above the head, comes down. What's that? Septum transversum. Special cells from what organs sit directly up against the diaphragm? The liver and the spleen. Stomach is kind of down here as well because esophagus goes through. So the liver's right up against the diaphragm. Diaphragm, part of that is made by the septum transversum. So there's special cells from the septum transversum contribute special cells to the liver. What are those special cells called? Kupffer cells. Those Kupffer cells act as macrophages, eating up bad things in the body, but they're in the liver. Okay, so septum transversum, endoderm, mesoderm, ectoderm, mesoderm. So if the Kupffer cells are coming from the septum transversum, then that must mean septum transversum, mesoderm, Kupffer cells, mesodermal derived. Makes sense. Track it all the way back down. Okay, all right. I remember some embryo. All right. Okay, so. Again, looking at the arcuate ligaments, this is the median, medial, and lateral. So really important when you're thinking about, you'll see this in the arcuate ligaments as well as the umbilical folds. You have these words median, medial, lateral. Median means one in the middle, medial, two on the sides, lateral outside of that. Okay, so in this case you have one median arcuate ligament, okay, here, and then you're going to have medial, AL, lateral over here. So what muscle is this? Psoas, what muscle is this? Quadratus lumborum. What is this vessel that comes off right after the aortic hiatus and is supplying the inferior part of the diaphragm? Inferior phrenic. What vessel comes off of the inferior phrenic to supply the thing that's right above the kidney? Superior suprarenal. Okay, so make sure we get track of the superior suprarenals. They come off of the inferior phrenic. Middle suprarenals come directly off the abdominal aorta. And then the inferior suprarenals come off of the renal artery. Okay, so they're paired, one at the top, one in the middle, one on the bottom. All right. Okay. All right. So now we have a 30-year-old male boxer. So we're getting fun. Presents to the emergency department the day after a fight. Okay, not a great start. Reporting blood in his urine. So already boxer, blood in his urine. I'm thinking, okay, is there something to do with the kidneys? Okay, did he get hit in the back? He also notes some soreness and visible bruising along his lower right back. It's almost like I wrote the question. On physical exam, there is significant tenderness to his right flank area. CT scan of the abdomen and pelvis is performed to evaluate the source of the blood in his urine, hematuria, and flank pain, revealing potential injury to a retroperitoneal organ. Okay, so what retroperitoneal organ is damaged here? Kidney. Okay, so what I really care about right? You got kidney, good. There's blood in the urine, kind of a clue. Got hit in the back. But what I want to know is what are the different structures that are retroperitoneal? Okay, so y'all probably seen this mnemonic before, sad puckers. Okay, this is helpful. Again, it's not, and you also be careful when you're looking online for different components. So you see that I've changed some of these because it doesn't align directly with what y'all need to know. But big things, kidneys, retroperitoneal. What sits directly above the kidneys? Suprarenal gland. So suprarenal glands are also retroperitoneal. All right, the aorta is retroperitoneal, as well as the big vein that's sitting right beside it, which is your IVC, inferior vena cava. The duodenum is retroperitoneal. Okay, what parts of the duodenum? So second through the fourth, as it's curved. So as the second part is the descending, what joins with the descending? The common bile duct, which is joined by the pancreatic duct. Okay, and that goes into the descending component. Then you have the transverse, which is being crossed over top by what vessel? SMA, superior mesenteric artery. If that compresses, it's called SMA syndrome, which presents like a small bowel obstruction. Then as you come up, you have the ascending fourth component. So that's all retroperitoneal. And then the second through the rest of the duodenum is supplied by what vessel? Midgut, foregut, hindgut. Remember, that's midgut. So that's the SMA. Okay. All right. So pancreas, most of it is going to be retroperitoneal except for the tail. Okay. So the tail is intraperitoneal. Because, do you see the spleen up here anywhere? Spleen is intraperitoneal. It's not retroperitoneal. The pancreatic tail goes and it almost touches the spleen. Okay, so you can follow it back around. So both of those are intraperitoneal. The ureters, they're attached to the kidneys. We said the kidneys are retroperitoneal. The ureters are retroperitoneal as well. The colon, what part of the colon? So on either side, the ascending and descending colon going to be retroperitoneal. All right, kidneys we talked about. Esophagus as it's coming through. Rectum, and we're thinking here the superior third. We'll talk more about the rectum like next. Or I think you talk about more next exam. And go from there. So this is a quick mnemonic, but again, what you really need to know, you're not going to go through and be like S-A-D, D-1. So you need to be able to get to it relatively quick. And the big structures here is recognizing that intraperitoneal is going to be the large majority of structures. So that's why we talk about what's retroperitoneal. If you know what's retroperitoneal, everything else must be intraperitoneal, okay, for the most part. And then down here, we're going to have subperitoneal, which is why the distal part of the rectum is subperitoneal underneath the peritoneum, because you're getting into the pelvic cavity in this region. Okay, questions there? All right, so we're going to do some bonus cases. So these aren't directly associated with the posterior abdominal wall. These kind of span some other things. We have time for at least one. So you have a 7-year-old boy brought in by the pediatric clinic by his parents due to swelling of his right scrotum, which they noticed over the past few days. Swelling appears to increase when the boy stands or coughs and reduce when he is laying down. Denies pain, discomfort. Physical exam, there's a soft, non-tender mass in his right scrotum that can be reduced when you put pressure on it. All right, the mass appears to extend superiorly towards the lateral abdomen. What do you think he has? He has a hernia. So I already heard specifically indirect. Why do you think this is indirect versus direct? What clues? So the big thing here is you're looking at age. So child, boy, kid, young, more likely to be an indirect. As you get older, weakening of the abdominal wall, more likely to be a direct hernia. So speaking of, let's go indirect versus direct hernias. Indirect hernias pass through what space? Inguinal canal, going down to the scrotum in males, because it's going to go, what other structure in a cord passes through the inguinal canal? Spermatic cord. So it's going to pass along the same pathway as the spermatic cords, which is why it ends up in the scrotum. Okay, direct inguinal hernias punch directly punch through the abdominal wall. What is the weakest region of the abdominal wall for them to punch through? Hasselbalch's triangle. Okay, Hasselbalch's triangle is bordered by what structures? So in the midline, we have two muscles that run down. So that's your rectus. So rectus is one border. I have the ligament that goes from my ASIS to my pubis. That's the inguinal ligament. And now I need one other border. This is going to be a vessel. This vessel comes off your external iliac, goes up underneath your rectus. Dr. Ziri talked about it yesterday. It's the inferior epigastric. Okay, inferior epigastric. That's going to form Hasselbalch's triangle. Why is this weaker than, say, anything above the arcuate line? Because if I go below the arcuate line, how many layers do I have posterior to the rectus? One, just a transversalis fascia. Okay, so transversalis fascia is there, so this is weakening because now everything else, the aponeuroses, are going above the rectus. Okay, so there's that. Inguinal anatomy. This is a little bit hard to picture, but here's a diagram if you want to see it. But the big thing is interiorly, you have the deep inguinal ring. It's passing through to get to the superficial inguinal ring, and the spermatic cord is coming through. And then we'll see as what is passing through in development, you have the testicle, which starts beside the aorta, and it comes down and descends. It has to punch through every single layer of the abdominal wall. Okay, and then it has to get down into the scrotum. So if you can backtrack every single layer of the scrotum back to a layer of the abdominal wall where it was derived. Okay, so the big things here, the testicle is coming down, and you can see I usually start deep, and I go, what are the layers around the testicle as I come through? I like to say testicle's coming out. The first thing it hits as it's going through the abdominal wall is what? Peritoneum. So peritoneum is going to get picked up. Then I keep going through. I'm going to get the transversalis fascia. I keep going through. Does your transverse abdominis give anything to it? No. Then I'm going to have the internal oblique. So I'm going deep to superficial. Internal oblique, the muscle that sits on top of the internal oblique. External oblique. And then I come out and I have fascial layers. So what's the fascial layer that is fatty? Camper's fascia, because I sit and I eat marshmallows and I'm like, this is Camper's fascia. Do know if they ask you in the OR what fascia is this, it's never Camper's fascia. Okay, it's always Scarpa's. Because they're like, med students come in all the time and say Camper's fascia, and we don't know where they're getting that from. So they're going to ask about Scarpa's. Don't ask me how I know. And then, then you're going to keep going through and you're going to contribute additional layers. So really for all of these testicular layers, you should be able to track it back to what are the layers of the abdominal wall as the testicle is punching through. Okay, and this is something that we referenced this, but the abdominal wall layers with a rectus sheath. So when you're thinking about this, we divide the abdomen into a superior, middle, and inferior third. We're thinking about those sheaths. So the one that I think is the easiest to just, once you have this, you got it down, the middle third. This is going to have the internal oblique aponeurosis is going to split into a superficial and a deep layer. Superficial layer goes above the rectus, deep layer goes below the rectus, and then everything above that has to be above the rectus. Everything below that has to be below the rectus. Okay, so once you have that middle third down, you're pretty set. And then we also said anything below the arcuate line is going to be everything on top except for the transversalis fascia. Okay, so that's kind of what we're thinking there. All right, cool. All right, do we have time for another one, or are we? Okay, all right. So now we're finally in the thorax. Okay, so we have a 40-year-old male presents to the emergency department after sustaining blunt force trauma to the chest during a motor vehicle accident. He complains of chest pain and difficulty breathing. Chest x-ray shows pleural effusion, which is fluid in the pleural cavity on the left side. A thoracentesis, needle into the thorax, is performed, yielding milky white fluid. Okay. Further analysis of the fluid confirms the presence of chyle, leading to a diagnosis of chylothorax. All right, so milky white fluid, is that an artery? Milky white fluid, is that a vein? Milky white fluid, is that a lung? No, there's air in there. So what is a milky white fatty structure component that might hold lymphatics that's in the thorax? So this is your thoracic duct. So this is a thoracic duct injury, and this is how this presents. When you do a thoracentesis, you get a milky white fluid as opposed to anything else. So the thoracic duct is going to be located in the anterior, middle, or posterior inferior mediastinum. Posterior. So this is when we're thinking about our mediastinal structures. What runs through each space? All right. So thoracic duct is draining what part of the body for lymphatics? Just about everything. The only thing that it doesn't do is what's done by the right lymphatic duct, which is the right arm, right half of the face. Okay, but everything else is coming from the legs. It's got to go up. It goes from the abdomen all the way up. And where does it insert? Y'all saw this last exam on what vein does it insert into? Yeah, it comes into the venous angle, right where the subclavian and the jugular come together. It's usually where you'll find it. Okay, so that's your thoracic duct coming around, and it makes that arch. Okay, so this is a lymphatic structure. Remember, lymphatics are important. I can't tell you the number one thing I know from testing. Lymphatics, I don't know why. Tests love lymphatics when you get to board exams all the time because of cancer. Cancer is going to, if it travels with lymphatics, infection travels with lymphatics. Which lymph node is involved when you have scrotal pain? Oh, aortic. Y'all learn that next exam, but it's all the time. So you got to know your lymphatics. Thoracic duct is one of them. All right. So mediastinal borders. Big thing here is we have a superior and inferior mediastinum. We split the inferior mediastinum into more components just to give us more ability to separate things. So the superior mediastinum, we use the line passing through the sternal angle all the way to the T4 and T5. So everything above that, superior. Everything below is going to be inferior. Inferior, we're going to have an anterior component, middle, and posterior. Y'all can use the pet bat mnemonics if y'all want. I will say I hate mnemonics, so that's my personal pet peeve. But that's mostly because if I get on the practical, I'm like, there's a structure, P-E-T. I just can't do it fast enough. I'm really slow. So that's the issue. But the idea here is in the anterior, inferior mediastinum, what structures are running? Internal thoracic vessels. Okay, in the middle mediastinum, that's where your pericardium sits, that's where your heart sits. Posterior, this is where all the other structures sit. And you can think about this logistically. If there is something that passes to my mouth and it has to get into my abdomen, it has to pass through behind the heart. So if I'm eating something and it goes down, that's my esophagus. Okay, my esophagus needs innervation. What innervates the esophagus? Vagus nerve. So the vagus nerve sits around it. So that's also in the posterior mediastinum. Okay, there's lymphatic structures that run down from my abdomen up to my neck. That's the thoracic duct. So those structures are all present. I've got to have blood flow. So I have I have a thoracic aorta, and then inferior vena cava. Is that here? No. Why? Because inferior vena cava comes through the abdomen, right into the heart through the cable, like the hiatus. And what is that level? T8. All right, and y'all know that I eat apples. Yeah, 8, 10, and 12 mnemonic. Okay. And then sympathetic trunk, not present. IVC, not present in the posterior mediastinum. All right, what sympathetics are present in the posterior mediastinum? Those splanchnic nerves that are coming across. And on the cadavers, you can see the greater splanchnic nerve coming across on top of the aorta, going down into the abdomen. Okay, all right. I think we talked about that. Oh yeah, this question. They did a thoracentesis. They pushed a needle into the thoracic wall. All right, where do they push it? Do they push it under the rib, in the middle, or above the next rib? Above the next rib. Why? Because we have the neurovascular bundle that goes right underneath every single rib. So if I go right under the rib, then I'm risking hitting the, depending on where I'm at, the posterior anterior intercostals. Okay, so it'll be, and then the neurovascular bundle always has the same order. The thing that is on top, touching the rib, is the vein. Then underneath that we have the, and then underneath that we have the, cool. Okay. Is this the last case? Yeah, okay, really quick. I'll fly through it. Super fast. Okay, so, all right, so 35-year-old male, ED, car crash, just the red things, car crash, chest pain, difficulty breathing, cardiac tamponade, which is fluid in the pericardium compressing the heart. Okay, so CT shows rupture of the aorta near the site of an it's site of an embryonic remnant connecting the pulmonary trunk and the aortic arch. So embryonic remnant, pulmonary trunk, aortic arch. Okay, so what is that structure? Ligamentum arteriosum. Okay, and ductus arteriosus in embryo. Okay, all right, so that's what we're seeing here. In decelerating injuries, this is a very common case to get. Decelerating injuries, the aorta is kind of locked into place. The heart is a little bit mobile. You have the heart shift. It tears at the site where the pulmonary trunk and the arch of the aorta are located, and that causes blood to fill that space. In this case, it's filling the pericardium, which is leading to a tamponade, which is just, again, pressure around the heart where the heart can't expand correctly. All right, I want to place a needle in order to alleviate this, because this person is dying on me. Their heart's not opening as well as it should. They're not getting good cardiac output. So where am I going to put that needle? Okay, so there's a bunch of different locations, but for the one for y'all's course packs, this is cardiac tamponade. Y'all want to know